Bismillahirrahmanirrahim. Assalamu alaikum students. Today's topic is prenatal diagnosis and fetal therapy. Previously I told you in my lecture about the non-invasive techniques. Today we will talk about the invasive techniques. So come to the amniocentesis. During amniocentesis, a needle is inserted transabdominally. It is inserted transabdominally into the amniotic cavity, guided by ultrasound, and approximately 20 to 30 ml of fluids are withdrawn. Here you can see amniocentesis. Here is the needle. Needle is inserted transabdominally. This is the abdomen into the cavity. This is the amniotic cavity in which fetus is present, guided by the ultrasound. So, during amniocentesis, a needle is inserted transabdominally into the amniotic cavity, guided by ultrasound, and approximately 20 to 30 ml of fluid are withdrawn. Because of the amount of fluid required, the procedure is now usually performed before 14 weeks of gestation. So, before 14 weeks of gestation, it will not be performed. Okay. So, it is the time when we will perform the amniocentesis, when sufficient quantities are available without endangering the fetus. The risk of fetal loss as a result of the procedure is 1%, but it is less in centers skilled in the technique. The fluid which we have taken with the procedure of amniocentesis, this fluid is analyzed for biochemical factors such as alpha fetoprotein and acetylcholinesterase. In addition, we have the fetal cells. Sloughed into the amniotic fluid can be recovered and used for metaphase karyotyping and other genetic analysis. So we have fetal cells within the fluid and we have the fluid itself. Fluid is analyzed for alpha fetoprotein and acetylcholinesterase, and fetal cells are examined for metaphase karyotyping and other genetic analysis. Unfortunately, the harvested cells, these fetal cells, are not rapidly dividing, and therefore cell cultures containing mitogenes must be established to provide sufficient metaphase cells for analysis. This culture period requires 8 to 14 days. So we need mitogenes to provide metaphase cell. So this will take time and it requires 8 to 14 days, and consequently making a diagnosis is delayed by the amniocentesis with the help of the fetal cells. Once chromosomes are obtained, when we have taken these cells and from there we have obtained the chromosomes, major chromosomal alterations such as translocations, breaks, trisomies and monosomies can be identified. So with the help of the amniocentesis, once chromosomes are obtained, we can detect the major chromosomal alterations such as translocations, breaks, trisomies and monosomies. With special stains and high resolution techniques, chromosome bending pattern can be determined. Furthermore, now that the human genome has been sequenced, more sophisticated molecular analysis using polymerase chain reaction and genotyping assays will increase the level of detection for genetic abnormalities. Once chromosomes are obtained, we can have these, we can see these abnormalities, as well as with special stains, we can have chromosome bending pattern, and we can have the human genome sequence, and we can increase the level of detection for genetic abnormalities. Now, after the amniocentesis, we have invasive technique that is called chorionic villus sampling. Chorionic villus sampling involves inserting a needle transabdominally and transvaginally into the placental mass and aspirating approximately 5 to 30 milligram of villus tissue. In this diagram, you can see that we can pass transvaginally needle and transabdominally like this, and we can have the placental tissue by it. So in this we can use two, that is we can pass the needle transabdominally just like the amniocentesis, or transvaginally we can pass it to get the placental mass, and placental mass we will have the 5 to 30 milligram of the villus tissue. By this sampling, cells may be analyzed immediately, but accuracy of result is problematic because of the high frequency of chromosomal errors in the normal placenta. Therefore, cells from the mesenchymal core are isolated by trypsinization of the external trophoblast and cultured. Because of the large number of cells obtained, only 2 to 3 days in culture are necessary to permit genetic analysis. Thus, the time for genetic characterization of the fetus is reduced as compared with the amniocentesis. However, the risk of fetal loss from chorionic villus sampling is approximately twofold. So, risk is twofold, but the time for characterization of the genetic problem is reduced as compared to the amniocentesis. There have been indications that the procedure carries an increased risk for limb reduction defects during chorionic villus sampling. Indications for using this test include advanced maternal age, 35 years and older, history of neural tube defects in the family, previous gestation with the chromosome abnormalities such as Down syndrome, chromosomal abnormalities in either parent, a mother who is carrier for an X-linked disorder. So these tests are not used on a routine basis. These are used when indicated. So this is all about the invasive techniques of the prenatal diagnosis. Now coming to the fetal therapy. Fetal therapy may include fetal transfusion, fetal medication. So fetal transfusion in cases of fetal anemia. When we have the fetal anemia produced by the maternal antibodies or any other cause, blood transfusions for the fetus can be performed. Ultrasound is used to guide insertion of a needle into the umbilical cord vein, and blood is transfused directly into the fetus. So if we have the fetal anemia, we can transfuse it directly into the umbilical cord vein of the fetus. So fetal therapy, in it we discuss the fetal transfusion if the fetus have the anemia, We can transfuse the blood into the umbilical vein of the fetus with the help of the ultrasound. Then fetal medical treatment. This includes that treatment maybe of the infections, fetal cardiac arrhythmias, compromised thyroid functions, or other medical problem in which fetal medication is needed. It is usually provided to the mother and reaches the fetal compartment after crossing the placenta. But in some cases, however, agents may be administered to the fetus directly by intramuscular injections into the gluteal region or via the umbilical vein of the fetus. So we can directly give the injection to the fetus into the into the gluteal region or via the umbilical vein of the fetus. So fetal medical treatment, when it is indicated, we can give directly or we can give indirectly through the mother. Fetal surgery can also be performed because of advances in ultrasound and surgical procedures. Operating on fetus has become possible. However, because of risks to the mother, infant, and subsequent pregnancies, procedures are only performed in centers with well-trained teams and only when there are no reasonable alternatives. Several types of surgeries may be performed, including placing shunts to remove fluid from organs and cavities. For example, in obstructive urinary disease of the urethra, pigtail shunt may be inserted into the fetal bladder. One, Once problem is diagnosing the condition early enough to prevent the renal damage. Ex utero surgery, where the uterus is opened and fetus operated upon directly, has been used for repairing congenital diaphragmatic hernias, removing cystic lesions in the lung, repairing spina bifida defects. Repairs of hernias and lung lesions have good outcome if proper selection criteria for cases are applied, and one of these is the fact that without surgery, fetal demise is almost certain. Surgery for neural tube defects is more controversial because the abnormalities are not life threatening. Also, the evidence is not conclusive that repair of lesion improves neurological function. Although it does alleviate the accompanying hydrocephalus by freeing the tethered spinal cord and preventing herniation of the cerebellum into the foramen magnum. So in this slide, we came to know that we can do the ex utero surgery, but we should do only for those with the skilled team at them at the good center. And repairs of hernias and negligence have good outcome as compared to the other till now. Now coming to the stem cell transplantation and gene therapy, that we can transplant even stem cell to the fetus and give the gene therapy. Because the fetus does not develop any immunocompetence before 18 weeks of gestation, it may be possible to transplant tissues or cells before this time without rejection. As we can transplant tissue without rejection before 18 weeks, researcher in this field is focusing on hematopoietic stem cells for treatment of immunodeficiency and hematological disorders. So we can transplant hematopoietic stem cells to the fetus before 18 weeks of gestation. Next to the gene therapy for inherited metabolic disease such as TSOX and cystic fibrosis is also being investigated. Thank you, students. It's all about the prenatal diagnosis. We have discussed invasive techniques and the fetal therapy in this lecture. Allah Hafiz.